today, just so you know, I've got no conflicts of interest today. I'm here from my own accord. Again, I teach at a family medicine residency program. Now, I think I'm the only pharmacist on y'all's agenda, so it's, see, you hear that y'all in there? I'm probably the only pharmacist that y'all going to have. And y'all, by the way, I just let y'all need to read, like, we start at 8:30 when our pharmacy, we do meetings. We start at 8:30. Y'all start at 7. Do doctors not sleep? What's wrong with you people? No, I'm just kidding. But anyway, I don't speak on speaker bureaus. I don't have grants, et cetera, related to this topic. Got a few paintings I'll show you that are all in public domain. I might show you. One thing I would like you to think about right now, to really take your medicine cap off right now. Really, put your philosophy hat on a second. Your understanding about humanity and life, sort of put that hat on now and sit back for a minute and look at some of these slides I want to show you. And I want you to think about some things. And the gear of this is to set up this afternoon. And what is going on in the world? It's crazy, isn't it? And you could say people have back pain and chronic pain, but there's more going on than that. And it's suffering. It's a side of suffering. And I want to, sort of dissect that just a little bit in what I'm going to do today. And a lot of this relates to this afternoon, but I really want to put on a sort of a philosophy hat for you for the 30 minutes or so I have with you, and just get you to sort of survey and think through those kinds of concepts. Because in medicine we have conundrum. This is my favorite word this year. I don't know where I got it from. I don't know where I heard it, but conundrum. Everything is conundrum. Conundrums are confusing, difficult problems. They're riddles. They are synonyms, maybe a brain teaser. I like this thought of a tension. And there's so many tensions in medicine. That's one thing I love about medicine. Being a pharmacist, I'm a non-doctor in a doctor's world, and have been so for 27 years. And, I'm just so fascinated by the whole medicine as a whole and what it sort of brings to life, because it's a major, complicated science, isn't it? There's nothing to me black and white about what y'all do. It's just as gray as anything that exists. And it's so gray when it relates to things like this. And, the medicine's full of conundrums. Have you ever been in the room? We were in the room not long ago. Excuse me, y'all, this little thing here. We were in a room not long ago, and the patient didn't have a pulse. The patient was like 84. And what do? Do you call a code? Do you not? Is the patient, what's the status? Of course, nowadays, we got all these committees that form. We have these rapid response teams. You don't have to worry about that as much. But you have all these conundrums, hiccups, a medical conundrum. You give somebody a TNF blocker and it increases their risk of psoriasis. You're using it for RA, but you increase the risk of psoriasis. It's conundrums, it's the tensions that form. The medical mobile conundrum, of access to information and how you guard for that. There's a tension there, big time. Do we use placebo in medicine? Of course we kind of do. It's kind of unethical to say we're using a placebo or actually do it. But, a placebo is, I love this definition I found from an 1811 article. Look at this. Any medication adapted more to please than actually benefit the patient. How many times have you ever run into that in your life? Big time. It goes on and on. Overdiagnosis. And I love to come to a women's conference and just throw this in here. Jesus Christ will separate a room. Mammography will separate it too. And, it just does. I love it. See, when we're talking about these things in medicine, it's incredible I love to hear our doctors, our young physicians growing, and hear what they think about, that whole concept. It's amazing. And, when you get down to, 50-year-old women and doing 10-year mammographies, this is a little thing. It comes down to, yes, we avert 10 deaths. We avert 10 deaths from breast cancer, but we have 57 overdiagnoses. It's an incredible conundrum. I don't care what side of the fence you sit on. To me, we need a better test, but, again, it provides so much tension in medicine. Polypharmacy, look at this slide. I met him at a park. I saw him at a park. I said, can I take the back of your shirt? I got to take a picture. So he leaned over and let me take a picture. If you can read it, let me see if I can read it. I take aspirin for the headaches caused by the Zyrtec. I take for the hay fever I got from Relenza, for the uneasy stomach from the Ritalin. I take for the short attention span caused by the scoped derm. I take for the motion sickness I got from the Lomodal. I take for the diarrhea caused by the Xenical. For the uncontrolled weight gain I got from Paxil. I take for the anxiety from Zocor. I take for my high cholesterol because exercise, a good diet, and regular chiropractic care are just not much trouble. Too much trouble. Just too much trouble. I thought, polypharmacy, using lots of medications. I mean, huge conundrums in what we do. I just had one of my residents came into the office. She said, Kelly, you got to help me. I said, what you got? She said, I got this lady. I counted her medicine. She's on 34 drugs. And I went and met with her for a while. She's going to come back next month, and we'll have a lot of discussion about it. Amazing teachings and conundrums. And this is the biggest one that's happened for us in a long time is opiates. Opiate therapy is causing a lot of tension because of this graph out of Perspectives article set in New England Journal of Medicine. If you see the rise in unintentional drug overdoses, 78% of those from opiates in their own right. Increasing deaths beyond things that we can imagine. More so than car accidents per day in a given state. It's amazing what has happened. And so we have, found ourselves, going from one end to not treating pain well enough to over-treating pain. I think that's kind of where we are with things. And we want to diagnose it. We want to help patients with it. We want to restore function as best as we can. We want to give them realistic expectations and give them the right understanding about what to expect from opiate therapy. We want to use multiple medications when we can, that kind of thing. But with pain, there's just something else going on here. The number one prescribed drug in the United States is hydrocodone. The second one are some of the stomach drugs. And the third ones are antidepressants. You can't ignore that. I don't care who you are. And, it's just amazing. Who said the stomach and the mind are not connected? That's pretty amazing. It very much is, isn't it? There's just something more about it that's happening in our nation. And I think it's a suffering aspect. And this is kind of the philosophical bent I want you to put on it. We do pain. There's physical pain, like lower back pain we see. But I've never seen anybody suffer more who couldn't catch their breath or who has anxiety to where they can't go anywhere. I've never seen any more harsh reality of life. The mental aspect, anxiety, grief, hatred, boredom, is a measure of suffering. And I wonder if that's not causing a bump in the use of opiates in our patients. And are we, what kind of pain do they really have in relation to what all is going on in their life? And is it causing us to use more opiates than we should? And are we just dosing the pain away, not just physical pain, but the suffering that goes on around us? C.S. Lewis said it well, a pain is a metaphor for a dying world. The Old Man and the Beard, one of Rembrandt's greatest. They think it's Rembrandt. And if you Google this tonight, you can't see it well here. But you look at his face and you can see all the curves and the dents and all the bumps. You can see the road of this man's life. And you can see the suffrage in this man's life through his course of time. We all end up with that. We all have our level of suffrage. My pastor at church, he said it well. I told him I was going to put him on a slide. He's like, what? Suffering is wanting what you do not get and getting what you do not want. So suffering is built into unemployment, shattered dreams, lost longings, illness, disease. It's more than just physical pain. And with the rate of people dying from it, I'm wondering if we're not treating our suffering as well as our physical pain. I think people do that, and it gets misused. Opiates gets misused big time. This is I love art. And I don't know if y'all know, but they have great art historians take this stuff, and they can go back and look behind the photographs. Y'all know that Rembrandt was a great teacher. He had a bunch of students. He was a preceptor. He had gobs of students. And what he would do is take a picture, a self-portrait of himself. He would put it up, and he'd have the students go over it And he would, so they would teach him how to paint with technique. You know, every heart historian, and most every heart historian believes that the old man with the beard is a student version of a Rembrandt, because Rembrandt probably put, this is the back of that, start of that picture, you can see the different micrograph scans of it. That was for free, you know, just y'all art history lesson. Picasso, the oceans of pain. Look at the stretching and the mouths open and the gnawing of it. You know, Picasso did it with this, and he tried to show exhaustion in it. We see these things in all around us. And people are different. You know, you're not what you eat. You're not what you wear. You are what you believe. That's what I think. And there are many different ways people believe, and believe about who they are and what they are. Hedonist sort of understanding, a hedonist is someone who seeks joy and pleasure out of things. What if you had a patient like that? He doesn't understand why they have any pain at all. Because if you have a patient who's a Buddha, I mean, that whole aspect, I'm trying to give you a religion lesson. I'm just trying to give you some thought process here. You know, the whole aspect of being holy is all about being free from pain and pleasure. And Kurt Cobain of Nirvana took a gun and blew his head off, and in his note he left, there is no joy here. There's no pleasure here. It's just pain and suffering. And he killed himself over it because he felt like he'd go to a better place. What if you live in the South, if you live in South Carolina, you look at Christian people, and they'll tell you that with pain is much wonder and glory. That's crazy the way people think. You are what you believe. What if you could turn your patient's ideas and thinking around that idea? You know, I take a risk to say this to you today. You know, I take risks like this, but I want you to understand the way people think and how they are. And, you know, if you take the average Christian person in Florence, South Carolina, they'll say that, you know, Christ's suffering is a good thing. That pain, I mean, you've heard no pain, no gain, right? You know, that's the idea. You know, and we think of the suffering Christ as the key to that understanding. And most people, if you take a person like that and help them understand that, they'll oftentimes get a little bit head start on their understanding of their disease and their pain and their you know, and maybe their suffrage of things, because Arthur Pink did it well. He said, through trouble, suffering, affliction, tribulation, that's how you get to God. It's through pain and suffering. So that's an amazing kind of thing. This is Martin Schogeller's, you know, amazing piece that everybody loves of, if you're an art historian, and you see the chaos and the pain and the suffering going on around. Everybody's looking in all directions, and part of what Martin did was only the Christ is looking at you. But you see the pain and suffering. And through that, Christians believe that they're healed by that. So it's a very different philosophy. You are what you believe. And that's a very key thing. So, come on, ladies. Why would any lady have a baby if there was no pain, no gain? So you got to think about these things as you treat people, I believe. I think you can't always... You can throw your belief patterns out the door if you want to. I don't think you can do that personally. We talk about that a lot at work. But you got to understand how your patient believes and how they think will help you better, I think, manage, especially opiate therapy for sure. This is the pinnacle. Edvard Munch, a painter, y'all can tell I like art. He was a bipolar. He was bipolar, probably one of the first well-known bipolar. Look at this quote. Let me just read it to you. This guy gets it. He gets it. My fear of life is necessary to me. That's that. As is my illness. Without anxiety and illness, I am a ship without a rudder. My art is grounded in reflections over being different from others. My sufferings are part of myself and my art. They are indistinguishable from me, and their destruction would destroy my art. I want to keep those sufferings. He gets it. He gets it. I don't know how we display that to our patients, but he gets it. Because he takes his sufferings and his pain and he makes good do with it. He makes it a part of who he is. And it doesn't stymie him. It doesn't put him to the floor. It probably didn't make him have to use opium in that day, and he really didn't. You know, so amazing stuff. You know, he did the Scream. could talk about that for a while, but he did the whole screen. Prescription drug abuse is going crazy. People are doctor shopping. There are pill mills all over the place. And I think we're losing our perspective between pain and suffering a little bit. Lots going on in the world out there related to this. And this is, just a plain old, I love the advertisements you'll find in the paper down in Florida advertising pill mills. Come, treat your pain, $50. If you buy the prescriptions there too, it's $99. And there's all these things. That's the advertisements you see, or you really used to see in the last 5 years in Florida. When you go to hotels and different places down there, you'd find these little flyers everywhere. See, don't you wish we'd go back to these, the good old days? More doctors smoke Camels than any other cigarette. Isn't that crazy? To me, as offensive as we would say that advertisement is today, that is today. Or ask your dentist. I would recommend Viceroy. Isn't that crazy? I love this one. Start your kid earlier in life. Drink Coke. For an active lifestyle, better personality, offers the body essential sugars. Every mother in the world is offended by something like that. But isn't that great? But I'd rather see that than some of this. Really would. But anyway, those are there just to be a little crazy. We found a few pills here, a few pills there, here pills everywhere. On the street where old MacDonald ran a farm. You love that? Here's the tension. The FDA has decided that all opiums are to be REMS drugs. Risk Evaluation Mitigation Strategy, which is a fancy word to say when a drug or class of drugs has an issue with it, then what we need to do is we need to put into place a program or program to try to mitigate the safety of it. And that's what they've done with opiates. How many of you in here, different places, your state, you have to do some sort of physician education for your license? Yeah. We do in South Carolina. We just started that. You have to have 2 hours. Today, the scope of pain will give you 2 hours towards any sort of state-controlled, thing that you need. It should work for that if you need it. So all opiates are that. To do what? And this is the tension I feel, I think is there. Undertreat. We don't want to undertreat people. But we don't want to have a harmful access either. And that's the tension. It's a conundrum. And how we sort of relieve that is really yet to be seen. Nobody really has a good understanding of that. But look at our narcotic use. I don't believe this. This is MMWR. A reference should be down there. It's on the next page. But read that. The narcotic use is 45,000 daily doses per million per day. 45,000 daily doses per million. There are 300 million people. If you say adults, 290 million or something, per day. Per million per day. That reaches up in the huge range. And I was talking about this one time. I had a young lady. There's a bunch of pharmacists in the group. She popped up and she said, Kelly, she said, yesterday we did 5,000 Percocets in one day. I said, you did? Like, what? She said, yeah, we dispense on the average 5,000 to 6,000 Percocet per day in a little North Carolina, in Lumberton, North Carolina, CVS. It's like, are you serious? And then I thought about it. If you get 240, that's probably 20 prescriptions a day. It's not that huge. But I was like, man, what is going on? And we were like almost double. Canada is in second place and Germany's in third place. Things we kind of have known about from unintentional overdose, which is related to opiate overdoses, is that it is rising above heroin and cocaine from 2010. We have some new data to suggest that might be now going back down because we've put some programs into place. 7 to 9 people a day in Florida die from prescription drug overdose. Amazing stuff. And you can see all the traffic. This is what got everybody's eye, was the higher traffic accidents. And we had a summit in South Carolina about this to actually address this. And there was a huge crowd. We had doctors, lawyers, teachers, politicians. Everybody was in the crowd. Very nice program done. And, visits to ED have doubled. Interest to substance abuse programs have tripled. The sale of oxycodone and methadone has quadrupled. So there's a lot been going on for sure. And that's that same slide again. I want to re-show that for sure. South Carolina, we had 510 deaths in 2009 related to opiate prescription drug overdose. How many of you, if you don't mind, not rhetorically, but how many of you in this room know somebody that has died like that? Anybody? I know two. Two people I know who were suffering for various reasons, overtook their medicine, probably drank alcohol with it, was in a serious current. Well, one I know was an alcoholic who was trying to get off alcohol, got on a benzo, wasn't doing well, was suffering with it. It was at home. He'd been so many times, they just treat him at home. He called a friend, but last we heard, he did one of these kind of things. You know, went outside, made a deal with somebody, and took a bunch of morphine. And they believe not to kill himself. Based on what we could tell, it was just he took morphine, and we believe he actually drank alcohol on top of that, and he woke up, dead. I say that's funny, but he didn't wake up. And, it happens, and it happens to people we know. I mean, it happens to people you know. There were 510 of those that happened in little old South Carolina. It's pretty amazing. At least thank goodness, though, one thing, we're 25th of the states. At least we ain't on the bottom of the top. We always either on the bottom of the top for most things. They're bad. If the top is bad, we're at the top. If it's bad, we're at the bottom. We're at the bottom. New Mexico's the highest. I don't know why people, Mexico's the most beautiful place I've ever been to. I've been there once or twice. I can see why West Virginia's number 2. No, I'm just kidding. Just kidding. Who won't live in West Virginia? Just kidding. And Nebraska's the least. But anyway, lots of sales go up. I got to hurry up, speed through some of this. Death has gone up when sales have gone up, etc. And I kind of figure I love this little evidence-based sort of quote here. I like the way evidence-based medicine rings, and this kind of helps me think about things. Enough opiates were prescribed last year to medicate every American adult with 5 milligrams of hydrocodone every 4 hours for a month. And that's the kind of amount. And something's going on. That's why I posed all this stuff at the beginning. You're physicians. You're not drug dealers, and you got to think about all this in perspective. It really is important. And these billboards are going up in South Carolina. This is one of them. Who's getting your drugs? It may be your child. So the whole idea of watching the adolescents in your home, that kind of thing. Kids now, in my day, how many of you remember the PJ parties? You remember PJ parties? Yeah, y'all do. Some of you in here. You pour the grape juice and fruit juices in the bathtub, pour grain alcohol in there. And everybody walked by the bathtub. Can you believe that you would drink out of a bathtub, probably from a college student? Can you imagine that? And that was the PJ parties. Now they have Skittle parties, where they put pills in a bowl. And this is from a cop I learned this from. He said they put pills in a bowl, and they play these games, and if you win the game, you take the pill. It's kind of the idea today. And this brings up the path. Let me just kind of just want to describe this to you for a second. The path of pain management has changed a bit. And I want you to hear this, because this relates to this afternoon. We can stay status quo. I don't think anybody wants to, but we can stay status quo. But this afternoon, if you're going to prescribe opiates, how do you do that safely? That's the idea this afternoon. And then there's a third one by Dr. Hockey. He did a lecture. It's on the Audio Digest, which a lot of these, I think, end up on, and through the Southern Medical Association. That is absolutely, I would recommend that. If you find it, if you don't have it on a slide, it's January 7th of this year, volume 63, verse 1. Or issue 1. He does an outstanding lecture on the third path, he says, which is maybe we can get these people off. And he has success after success of asking patients, you've been on opiates for a year. How do you feel this year compared to how you felt last year? And when they come up saying, I'm no better, I feel worse, I've had to escalate my pain medicine, I'm on more than just one now, I don't like it. And he says he can take those people, he says it takes him about 6 months or 8 months. But he has got a number of cases of he has come off therapy completely. And you know what those patients tell him? They say, thank you. I feel the best I've felt in forever. So he brings up that other, and not just him, a lot of folks in your world are saying, maybe we don't have to do that chronically. Maybe there's other ways to get around this. So, because we think, oh, they're hurt, they're in pain, therefore we use opiates. They're saying, maybe you don't. I would encourage you as physicians, and again, I'm just, being a pharmacist, this is kind of my world of understanding, but teaching physicians like I have, we've played this several times in noon conference settings, and the more I listen to it, the more I think I don't know that I'm getting more like this and trying to understand it a little more, and that's what we need to do in medicine for sure. Education. Pills kill, pain doesn't. This is what these cops are telling me. You cannot arrest away this problem. You can't arrest it away. Obama has a 4-point plan that he's put forth now. Law enforcement, prescriber education, which is this afternoon. Take-back programs, get the DEA in places where they can take back medication, and state drug monitoring programs. How many of you have a state prescription drug monitoring program? Are you involved in it? If you're not, get involved in it. I think that's critical so you can do that. He's hoping that when all states get on board, it'll tie into a federal system, and we'll be able to see it from a federal viewpoint. But one thing, I don't want to scare you here, but law enforcement was number one. And he's not talking law enforcement of patients. He's talking about prescribers, which is a little spooky. And this afternoon, part of the discussion in this afternoon is, if you're going to prescribe narcotics, opiates, if you're going to prescribe them and you're going to do it, you won't do it well, you got to have a system in place to do so. You got to have policies and procedures in place. You really do. And you really got to all be on the same framework, your practice, in doing it right. You need a template in your EMR. You need to do those things that actually promote your safe and well-being. Because you don't want the little guys with the little black ties coming in and going, hey, we want to review your records, That's not good. And I would encourage you, if you're in a practice setting and you have someone in your practice that seems to just be on the bell curve, at the other end of the bell curve, as far as how they do things, how they do it, you really need to take that serious. You need to try to get that person on board with things and really do it right. Or, I worry about that aspect of things for sure. So the FDA put forth a blueprint for a REMS type program, and this is the different things. And to be honest with you, what they're focusing on is the long-acting agents, the long-acting drugs, because these one tends to be targeted out in the world, and they get the best price and that kind of thing for sure. And the two things of the REMS right now is prescriber education and patient education, and you'll learn today, or learn this afternoon, those who are with me, that patient education is a part of how we do some of the other areas as far as agreements, prescriber-doctor agreements, and that works pretty well too. Things you can do, prescribe less. You don't give, my wife had, speaking of OB, since y'all are into women's health, a lot of you, my wife had to have a D&C. We lost a baby, and it was a trying time for us, but not a horrific procedure. Her OBGYN, boy, that didn't come out right. He took her to the hospital. He sedated her, did a D&C, and he gave her a prescription for 30 Percocet. We didn't even feel it. She took one Motrin, seriously, literally. The next day she took one Motrin. And he gave us 30. And I didn't say it. I was just sitting back going, that's the kind of thing you got to, give 5, give 4. Don't give 30. So watch your prescription. And even some insurance companies are watching for that kind of thing as well, as far as they're only paying for a certain amount. That's been part of things. Take-back programs, getting the DEA to do take-back programs. That's interesting, though, isn't it? When you let all the federal DEA people come to the community, people can bring. I lost my mother to ovarian cancer, and we had 4 or 5 boxes of fentanyl patches. What do you do with them? Well, you take them to the take-back program. Of course, when I left the take-back program, I thought, the guys that were taking it, I thought, man, it's suspicious. I'm sorry, I'm not a conspiracy theorist, but I was like, gee, what are they going to do with it? You know, they kind of look like they would, they kind of look like they would do something else with it. I don't know. Ruling out mental illness is things you can do. That's helpful. Set guidelines, clear expectations, have contracts. All this will be at the scope of pain thing this afternoon. That's that particular thing. And by the way, their website, give you a pro. Those who are not going to be here, keep that website. It is absolutely phenomenal. And I'll explain that to the other ones that will be there, but you can prowl around in it. But it is a very good website. Things we can do, we need some research. From a compassionate standpoint, I want to relieve pain. Sure I do. From a realistic standpoint, I want to improve function. But you know what? There is no evidence on it. It's incredible to me. There was a systematic review that the National Institutes of Health asked some physicians, and I forget which university it was, to do a systematic review on this issue. And they evaluated the effectiveness and harms of opiate pain for chronic pain. They evaluated 39 studies of 4,000. They pulled 4,000 articles. They got 39 that fit their criteria. No study of opiate therapy versus placebo or another non-opiate therapies were greater than a year exists for related outcomes on pain, function, or quality of life. No randomized controlled trial evaluated opiate use, addiction, or related outcomes on long-term opiate therapy versus non-opiate therapy. Have you ever seen a goose egg in medicine? I have never seen zero of nothing. Yeah, it's just amazing to me. There was no studies on effectiveness of long-term opiates in chronic pain. And that's what we got to do. Here's you might say, well, what are we going to do from all this? The thing we need to do is we need some research. We need research bad, really bad. And these are the kind of things they found. One study documented long-term use, which was 90 days of therapy within a 12-month time frame, versus no therapy. The drug was associated with increased risk of diagnosis of opiate abuse or dependence. So they saw more negative things than they ever saw positive things when you look at it from that standpoint. No study has evaluated the risk of falls. We always think you fall. Do you know there's a study actually in the elderly that show when you come off the narcotic, they fall more because they're in pain and they actually fall more. There's actually a study on that, actually pretty interesting. So they actually, our whole view of, well, you can't give that to the elderly. Our little buddies that walk around, our pharmacy consultants, and they do the beers list, you can't give that. Sure you can. I mean, actually it might be more helpful because those patients may actually have less falls. But we don't know a lot of that. We think that because we rationalize it. We don't have a lot of good research on it, and we need more research on these kind of things. Evidence is insufficient to determine the effectiveness of long-term opiates for improving chronic pain function. This is the appeal. If any of you in this audience works with the National Institute of Health, has a friend in the National Institute of Health, has anybody that has any power related to research, send them a letter and say, we need research in opiate management of chronic pain. We just do. We even need it for not chronic pain. And you can see the odds ratio for harmful things went up for fractures, et cetera, motor vehicle accidents. It's always harm that's just pointed to. It's nothing positive. So maybe Dr. Hockey's right. Maybe we ought to rethink about how and why and who we use chronic opiate therapy in. Great little essential article, nice little article in AFP that sort of outlines, not just tell you what to treat, not to treat, but how to do it in the sense of policies and procedures. Okay? I mean, I think that's a wonderful thing. If you don't have any sort of systemized approach to this, I would caution you. I think you need that somehow. You need to get together as a group. You need to figure out how to do it. Let me offer this to you. With our family medicine residency program, we have 26 residents that we're training. Our residents and our faculty have to go through the policy that I essentially have written based on a lot of this stuff that the faculty have approved. And I'll be glad to send that to you. My first slide should have my email address on that. Say, hey, I saw you in Kiowa. Send me your guidelines and policies. And I took all our McLeod name out, all our hospital name out. So I have a version that's sort of virgin, and you can look at it, and I'll send you to it in your WordPerfect, not a PDF, and you can just slice it up and dice it up. But I've taken this article and other articles like it, and I have systematically used it and put it in a position to where I think you can use it for your practice, and I'll be glad to send it to you.